So in a medical apprenticeship, it seems like the true cognitive apprenticeship where you have small groups of learners where the expert is the practicing physician who models his expertise to learners in a small group situation. And they provide feedback in the context of these small group situations. That's the pros of the typical medical apprenticeship. But the cons of this typical medical apprenticeship is that sometimes it really depends on the expertise of the tutor. Is the expert able to give the proper level of feedback? Are the explanations at the level that the learner needs to hear? Explanations may be way over the head. Students may not be listening, even if it is a small group. How can you monitor everyone, even in a small group? Can you diagnose that every individual in your group is learning or they have misconceptions? And the most important thing is that you only see cases that are occurring at the time that these patients are on the ward. So it's sort of, as they come in, you see that part of the curriculum, but you may not cover the whole curriculum because it's opportunistic teaching rather than sort of a standard curriculum. So what I've been working on is a system called BioWorld, where I situate learning in the context of patient cases and provide them with practice opportunities to practice their diagnostic reasoning. And I encourage metacognition by having them post their evidence as they formulate hypotheses in the context of problem solving and provide them with models of expertise. BioWorld looks like this. It's very case-based, where you have patient cases in the center and you stipulate your hypotheses at the top left-hand corner. And you have a patient chart where you can conduct diagnostic tests. You can ask for help in the context of learning. And you're posting your evidence as you go along. I'll just run a quick little snapshot of how it actually works. So here's a patient case, and students are looking at the text and they post what they think is important. Forced circulation, you can read that sore throat. What's the evidence of their hypothesis that they're selecting there, that these symptoms are important to their hypothesis? The belief meter is how confident am I that infectious mononucleosis is the hypothesis? They can go back and forth between the problem scenario at any time. They can read about diagnostic diseases and diagnostic tests in the library. And in that way, they can still collect evidence as they're formulating their problems. And they can conduct diagnostic tests in the context of each case and see how the test results influence their judgment. So it sort of gives you a way to look at an interactive problem-solving environment where BioWorld is collecting all of the data that students are doing in the context of this problem-solving exercise. I'll just move on because we won't have enough time to go through everything. The way it's based is really looking at the cognitive components of various cohorts and the learning trajectory for different age groups of students using BioWorld. Expertise, we've been able to look at ways of scaffolding the less proficient become more proficient in the context of working with BioWorld and helping them self-regulate their performance. And the next step is really looking at their emotional trajectory in the context of learning with BioWorld. The way we build expert models is looking at human medical instructors. As they solve BioWorld cases, we ask them to do think-alouds as they perform these cases, and then we can develop very complex decision trees to see how experts think and whether experts agree on how you might solve particular cases. And we've developed a methodology to sort of look at reasoning in the context of visualizing these decision spaces. Genevieve Gauthier was one of my students that worked on this part of the task. And what we need to do is look at multiple data sources in the context of learning. Looking at the BioWorld screen recordings, looking at BioWorld, what we call slime trails of performance, looking at audio, looking at transcripts, and putting this all together through qualitative analyses, we can look at how people think, and we come up with these very complex, multi-layered decision trees of how people are solving problems. And we can look at various experts and see whether they agree or don't agree on solving these cases. And that this knowledge is then underlying BioWorld so that we can assess students against a level of expert consensus. So we've been looking at BioWorld for some time, looking at mapping changes within and between subjects over the cases that they're solved in terms of their reasoning, the evidence collection, their library searches, competence, and how their decision paths actually support their hypotheses in a systematic way, how accurate they are, and how efficient they are in collecting data in the context of BioWorld. We found that over time, from pre-post test situations, there's a decrease in the number of diagnoses for pre to post tests, and that there's an increase in the organization of or cluster of diagnoses, and that the questions that they ask are more on target from pre to post. And I'm not going to spend time on all of the different ways that we inform the individuals of their performance, but we do have individual reports after each case for individuals to explore how they learned in the context of their peers and also in the context of experts. And they can look at their differential diagnoses in terms of how they compare to others. And we also have instructor reports that help the teacher realize how close each student was to an expert path, where the misconceptions were, and the instructor can use these to debrief his students afterwards. How much help did they ask in the context of solving cases, and where did they ask for help? So there's a lot of diagnostic information that's collected throughout BioWorld, quantitative data as well as qualitative data. The qualitative data shows us things like there's a greater awareness of diagnosis as a process rather than an outcome. Like, how did they reach the solution, not that they got the diagnosis right. And so that just sort of gives you an idea of what a student had said. I kept thinking that it was the drug itself causing all the vascular problems, and didn't recognize the problem of a 37-year-old woman actually having high blood pressure that required treatment in the first place. So I arrived at a drug-induced arrhythmia, which could have explained her symptoms, but it would definitely be more likely in an older patient with more risk factors for essential hypertension. I have to pay more attention to the baseline evidence of the patient rather than just focusing on the most recent data. The other quote showing how their approach might be different from an expert. So it's really getting them to think about what they did, how they compare to others, and what information they were good at using and what information they were not good at using. So the next steps for BioWorld are really looking at multiple experts, what they agree on, and how we can use this as better ways of scaffolding the learner, and to help novices think about the visual representations or decision trees that we've been using for expertise to help them reflect on their learning. And now we really are trying to move to the role of affective feedback. And one of my students, Laura Naismith, is going to be looking at how tutors might use affective feedback in the context of each case, and what is the role of affective feedback in BioWorld. And we're interested in kind of moving into a new direction. Does cultural background of the physician or the patient influence the degree of receptiveness, communication, interactions, or credibility? And finally, does emotional patient content affect the physician's decisions, reasoning, and confidence levels? And things like physician's mood, does that influence decision making? Okay. So I'll move to the deteriorating patient, in which we have Dr. Jeff in the back, who is my favorite subject. This is a different way of looking at affect in medical decision making. And what Dr. Wiseman has done is developed a role play simulation, and he's developed different forms of this role play simulation. Sometimes he plays the patient and the nurse, and the students have to react to him, giving, asking for appropriate diagnostic tests being done with this patient, getting the results of the diagnostic test in the context of the role play. And he sometimes just does it with a one-on-one with the student. And so he'll be working with the student until the student sort of says, "Uncle, I don't know what to do next," and passes the baton to the next student to try to solve the problem. And so his acting abilities are quite good. And here it is. Here's him acting out in response to something a student was saying. Okay, well, normally people burst out into laughter when I show this because he's really simulating a seizure. And what we don't realize is, even though it looks funny, the medical students don't see it as funny at all. What you see is that they're really getting stressed out. Their faces are flushed, and they're nervous that the patient is dying. And so context is everything. And when actually Dr. Liu here was studying Jeff in her dissertation research, it was her research that moved this into a direction of looking at collaborative learning with the deteriorating patient, and also looking at use of technology and how we might support student learning in the context of the deteriorating patient. And so we were moving away from just the one-on-one tutoring interactions to looking at how groups of learners could work together to solve these role plays, and how technology could support the decision making in this context. And we looked at human scaffolding as well as the use of technology in the platforms that we used. And the goal was really to increase active participation of the group, rather than, once again, if you have a small group and the tutor is tutoring a learner, the rest of the group is quiet and observing, what I might even call lurking. And so we were trying to get everybody involved to see what they were thinking while this role play was happening. So how do you decrease the bystander phenomenon? So we looked at computer tools using smart boards to support collaborative medical decision making, making the arguments that students were making in the context of decision making visible. And the question was, does technology supported teams, do they develop higher levels of metacognition and co-regulation than teams that are working together without technology support? So again, this is Susan's work, where we see Dr. Jeff in the group of the technology here on the left-hand side, and people using whiteboards. The laptops are sharing their problem spaces as small groups from the whiteboard to their laptops, and annotating the arguments that are appearing on the whiteboard. Then there were groups that were not using technology, but just talking together and collaborating to solve these problems together without technology support. So some of the interactions look like this, where you see some of the added annotations on the left-hand side. The pencil writing is obviously documenting the problem space as the teacher and the students are working, but the group effect is being added by the typewritten things on the right-hand side. So what does this annotation toolkit provide? Well, what we found was that the technology tools, the collaborative tools, were actually supporting reasoning, dialogue, and metacognition, in the sense that those that were in the technology group developed common ground earlier than those that were collaborating without technology. And what Dr. Liu was able to do was, looking at the discourse, identify and code the communication in terms of decision making, planning, orienting, activating, and sort of looking at the two groups to see where planning was occurring, what the context of the communication demonstrated in terms of decision making, and found that the technology group did almost all of their communication up front early on that was supported with the technology, establishing common ground so that they didn't have to spend so much time collecting information all the way through the problem-solving event, so that they could manage the patient case faster than the non-technology group. So it reduced the time to develop a shared understanding, and the way she was able to do this was by collecting multiple sources of data between student-student, teacher-student, and the computer annotations.